Now moving on to our third section, that is the approaches to the radial head. Now we have discussed briefly in the first two sections, that is first the radial head fractures, how they present, and what is the pathophysiology, what are the how to make a diagnosis, and what is the treatment of different types of the radial head fractures, especially Mason type 1, 2, 3 and 4 accordingly. In this section, we will be discussing what if we are going for open adduction tunnel fixation form of operative, how to go about these things, what are the approaches to the elbow, especially the Kaplan and the Kosher approach, and how to do radial arthroplasty and what are associated complications. Now the mainly approaches towards the elbow, especially if we are going towards the lateral part of the elbow, is the mainly two approaches. One is the Kaplan and this is Kosher. Kosher is more posterior lateral approach. Kaplan is more anterior lateral approach. And if you see the elbow over here, this is the point the radial head is. If you're going more anteriorly, it becomes Kaplan. If you're going more posterior, it becomes Kosher. What are the key steps in the Kosher approach? We have to incise the posterior fibers of the supinator, then incise the capsule in mid-radiocapitular plane, anterior to the crista supinatoris to avoid damaging the lateral ulnar collateral ligament. Why it is important? Lateral ulnar collateral ligament is the main stabilizer in terms of ligaments which are present on the elbow joint to the valgus stress or valgus dislocation of the elbow. Pros is the most important point is that it is more posterior lateral, therefore there is less risk of posterior interosseous nerve injury than the Kaplan approach, because it's more posterior. Now coming to the cons, the negative is basically the risk of destabilizing elbow if the capsule incision is too posterior, which tends to sometimes you go more posteriorly, resulting in radial lateral ulnar collateral ligament injury. Now injury to the lateral ulnar collateral ligament produces valgus instability, and post-operatively the patient will complain of this increased instability and pain at the elbow joint. Now coming to the Kaplan its own pros and cons. The Kosher was between the internervous plane was basically the extensor carpi ulnaris and aconius, where in case of Kaplan it's more anterior lateral and it is between extensor digitorum communis and extensor carpi radialis brevis, which is actually supplied by the posterior interosseous nerve and radial nerve, while in this case it was also between the posterior interosseous nerve and the radial nerve. And now coming to the key steps, mainly it's more anterior lateral. The mid fibers of the supinator and incise the capsule anterior to the mid radiocapitular plane and have access to the elbow joint. What are the pros of it? The pros of it is because that is more anterior lateral, therefore the damage to the lateral ulnar collateral ligament is quite less. And this means it's more stable approach. Post-operatively, the elbow instability and pain is decreased, and more better visualization of the coronoid, because sometimes they're associated coronoid fractures as well, especially in the case of terrible triad of the elbow. But the cons are actually it increases the risk of posterior interosseous nerve injury. Posterior interosseous nerve injury can be damaged and then can result in the paralysis of extensor digitorum communis, which itself could be problematic later on. Now coming to the complication after the excision. As I told you, usually the radial head is not excised. The primary goal is to at least sometimes we have to go for fracture fragmentation and removal of those fragments, but not all of the radial head is excised. But if we have to excise in a young adult patient, what are the complications which can be seen with especially the Kosher and Kaplan approach? The most common complication are the wrist pain, muscle weakness, valgus elbow instability, heterotropic ossification, arthritis, proximal radial head migration, decreased strength, and cubitus valgus at times as well. So these are all which can be possible with the Kosher or Kaplan approach, especially because we are going towards the elbow from anterior laterally in form of Kaplan or posterior laterally in form of Kosher. Now coming to the radial head arthroplasty. If you have done the radial head arthroplasty, whether we use of a Kaplan approach or a Kosher approach, then we have to go for most of the time the radial head excision is first done, that is replaced by the metal prosthesis in form of a radial head. Now, there are two types available, mainly the loose stem prosthesis, and the other is a bipolar prosthesis. Bipolar version, this is the radial movement occurring along with the coronoid, and this is actually occurring with the radius shaft. Actually, this is what happens. But what are the complications of sometimes radial head arthroplasty? As you know, you're restoring the radial head, which means all the complication of radial resection are removed. But the problem is overstuffing of the joint, then it leads to capital wear and problems and malalignment instability. Eventually, arthritis of the elbow and eventually the pain and instability can still set in over the long period of time, especially when the large radial head especially is utilized. Now, with every surgery, there is pros and cons of it, and we are managing conservatively, especially in the case of Mason type 1. A lot of complications surgeries are avoided. But when we have dealing with Mason type 2 and 3 injury, it's displaced and it's comminuted, then probably we have to go for open reduction and tunnel fixation. But with every surgery, it has its own complications. The most common is, especially we have reduced the fracture, we done the T-plate over there, but resulting in a redisplacement of the fracture. Maybe associated with posterior atrocious nerve injury. There may be later on loss of fixation, or there loss of forearm rotation, especially the pronation supination is affected most of the time. Or there could be elbow stiffness. Post-operatively, sometimes the patient does not move the elbow much due to pain, and this results in elbow stiffness at times. This could be due to radiocapital joint arthritis or infection at times, although it's very rare, but yes, in less than 1% of the cases, infection can occur. Heterotropic ossification, not all patients are prone to this, but yes, the most operatively there may be heterotropic ossification, which will eventually lead to elbow stiffness and pain later on. There could be hardware loosening and complex regional pain syndrome. All these could be associated with the surgery of the radial head, whether we are doing open reduction tunnel fixation, whether we are doing a radial head arthroplasty, or we are just doing the fragment excision, especially if the radial head combination is less than 25% of the case. In this section, we have briefly gone through the two approaches towards the radial head surgery. As you know that with Mason type 1, we don't need to operate, but with the type 2 and 3, we probably have to go for open reduction and tunnel fixation. Open reduction and tunnel fixation could be in form of two approaches. Either it is the Kaplan approach or it is the Kosher approach. Kosher is more posterior lateral. The pros of the Kosher approach is that there is less chances of injury to the posterior atrocious nerve. The cons is that there is increased chances of injury to the lateral ulnar collateral ligament. While if we are going with the Kaplan approach, it's easily accessible, it's more anterior lateral, but the cons is actually the increased chances of damage to posterior atrocious nerve. Although it has a better chances as compared to preservation of lateral ulnar collateral ligament. As with every surgery, there are definitely complications. Complications could be innumerable, could be infection, instability, hardware loosening. There could be heterotropic ossification, complex regional pain syndrome. So we have to consider the patient as accordingly. This could be the possibility of surgery, and plus above all, we have to consult the patient because there is increased combination. If it is type 3 or type 4 that is associated with elbow dislocation, that itself holds very poor prognosis. Thank you very much. Keep watching sqadia.com.